starting off, Des, would you like to tell us what are the good things that are happening for older persons in Ireland?
Sure. Which like this works, is it? Yeah. Yeah, no, I mean, quite a significant change has happened and there have been developments. So, for example, I was the 9th or 10th geriatrician in Ireland in 1993. There are now over 130. There are integrated care teams out in the community. Through the work we've done, acute stroke care is now largely run by geriatricians. There were no stroke units back in the early 90s. Memory assessment services, home care packages, regulation of nursing homes. There's still much work to be done. Regulation alone cannot develop quality of care. So, and probably in the background, two more important things is not only has our longevity increased, but our healthy life expectancy has increased. The number of years which we'll be healthy. And indeed, one of the challenges sometimes is because we're better at actually giving people a label of mild diabetes or mild hypertension, it sounds like people are growing older with more conditions, but they're actually being picked up. But the other thing that's of interest, and again, without in any way negating the fact that we support each of us who has memory problems related to dementia, thanks to Donna O'Malley bringing in free education in the 1960s, we know that the incidence of Alzheimer's disease is dropping in nearly every developed country in the Western world. And when they went to look at what was the most important part of that, it was actually education. So Donna O'Malley probably did more for health in Ireland than many another actual minister for health. Yeah.
That's extraordinary. That's very hopeful.
Yeah.
That's a very hopeful message.
Yeah.
I suppose one of the things that we see, as you know, in the research about and the data that comes out from countries who already have legalised forms of assisted suicide or euthanasia, is about older persons feeling like they're a burden on their families. If a patient of yours asked you that, how would you approach it?
Well, my general feeling, and again, I've written about this, I was interested in a documentary where Terry Pratchett, the author, went to Dignitas. And it really is about the stress that such a decision puts on the rest of the family who don't want to see the loved person going, but on the other hand, don't want to leave them alone. But I would generally say to people is not wanting to be a burden is actually probably the biggest burden of all on those around you. It's effectively second guessing your family, your loved ones and society. And in fact, in an odd kind of way, it's undermining your own impulse to understand solidarity and care. So not wanting to be a burden is something we must absolutely try and avoid. And I think the issue here is to ease burden. Sure. And in fact, one of the things that bothers me a little bit, sometimes we in the healthcare professions can unwittingly add to this by language. You mentioned the importance of language. So we have scales out there to measure the challenges of caring, but it's called caregiver burden or carer burden. And really what we should be talking, most of us want to care, caring is part of our moral development. We should be actually using language which says the burdensome aspects of caring rather than carer burden. Mm-hmm. So not wanting to be a burden is a burden in its own right and something we should be discouraging actively.
100%, absolutely. Gordon, may I ask, why have you chosen to work in this area? What drew you to it?
Well, I've worked essentially as a political campaign policy officer for the last 25 years or so.
Sorry.
Sorry. Since I've worked as a policy officer stroke campaigner for the last 25 years or so in Scottish politics initially. And one of the first bills that came before the Scottish Parliament when it was set up was what was called the Adults with Incapacity Act. Okay. And they were trying, it was a good piece of legislation, but there was an attempt to have legally binding advance directives inserted into that. And so essentially one of the first issues that arose in terms of policy debates at Holyrood was this issue of euthanasia and people requiring doctors to actively be involved in ending their lives. We did actually have some success on that bill. We got a clarification from the Deputy First Minister that the bill was not in any way going to introduce euthanasia. But then there were subsequent attempts. There was another attempt a few years later, and then there was a bill introduced in 2010, which was a euthanasia bill, both for people who were terminally ill and chronically ill. And then there was another attempt in 2015, and all of those attempts have failed in the Scottish Parliament because we formed a little group to organise a campaign opposed to it. And so when my predecessor moved on to a new job, I applied for this job 4.5 years ago, and interestingly enough, fairly soon into my this new job, Dignity in Dying, which is one of the main campaign groups in the UK, was pushing very, very strongly for a government inquiry to be launched, and there had been work done within the Department of the Ministry of Justice, and the Secretary of State, who was personally in favour, we understand, was about to launch that inquiry, and then that was overruled by number 10 Downing Street, and so it didn't happen. But they eventually managed to get a parliamentary inquiry, which has been looking at the issue for the last 8 months or so, 9 months, and will probably publish a report in the next few months. But the interesting thing is, I think that all their attempts have never managed to break the dam yet, despite 25 years or longer of campaigning on their part.
Big achievement.
Excuse me.
She's like to ask the
Oh
question.
no, you're grand. You're grand. You're grand. Thank you very much, Gordon, and for taking us through the history of the development there. Alex, there's been, I'm sure, as you know, I'm sure you hear this so much from where all the countries you attend. We're hearing so many worrying reports coming out of Canada about the practice of euthanasia over there. Can you tell us a little bit more, or?
So I told you a few stories, and there are some missing. So for instance, you referred to a couple stories in your own slides. So it was interesting, we recently had this case of a woman in Ontario who is a quadriplegic woman since the age of 17, and she never actually ever applied for disability benefits, even though that's fully available to her, because she had always been employed. When she was younger, first she was a student, and then she started writing some books, and she got involved with different disability organizations and things, and she started her own thing. She was a great entrepreneur, and then earlier this year she became quite sick. So that happens to people, especially people with disabilities over quadriplegia. They often might become very, very sick. Their body's having a disability makes that a not so good situation at times, and so therefore she applied for disability benefits in Ontario, and she was told that in Ontario, my own province, it takes 6 to 8 months to be approved for disability benefits, even though she's obviously, you don't need a lot to look at her to realize she's a disabled person. My own son Peter is autistic, so I could see them wanting, if you're having an autistic person apply for disability benefits, I could see that there might be some assessments they want to do, but in quadriplegia, I don't know how many assessments they actually need. Nonetheless, she was told 6 to 8 months in order to receive disability benefits, but she then applied for medical aid in dying, and she was told she was on the 90-day track because, of course, she's not terminally ill. So she went the full 90 days. She was in the media quite a bit about it. In the end, she didn't actually want to die at all. She just wanted to say she wanted her disability benefits. In the end, she actually got better and now is working again. And I don't even think she's receiving disability benefits. Some of these stories, I say, you can't make them up, because the fact of it is, if you made them up, you'd be looking ridiculous. So I'd say you're crazy. If I were to have told you stories, this could happen. So in 2015, if I were to have said to you, this is possible and that's possible, you'd say, Alex, I think you're being extreme. But in fact, these are the kind of things that have been happening. When I talk about the different things see, I'm also a member of the Delta Hospice Society. I'm not just a member, I'm on the board. And so what happened, just so you know, how euthanasias affect hospice. So I think hospice, good end-of-life care, is essential to all of us. But then what happens is when we legalize euthanasia, it ends up changing hospice. How did that happen? Well, first of all, of course, the idea that killing can become a part of, or an alternative to, or whatever, once again changes the philosophy right off the bat. But secondly, many of our governments said that they had to provide euthanasia. So what the argument was, that if you're accepting government money for your hospice, and you're not religiously affiliated, that's how they defined it in Canada. If you were not religiously affiliated, then you had to provide the option. So the Delta Hospice Society is near Vancouver, and they refused. They said, no, we're a hospice. In fact, the location of the Delta Hospice Society was directly across the street from the hospital. So, transfer is done all the time in medical treatment. Not every medical institution offers all medical options, you might have to be transferred, right? That's a normal thing. In this case, transfer was not even a problem. If someone they had a couple patients who had asked clearly that that's what they wanted, they were just brought across the street to the regular hospital where they could have euthanasia. Now, it doesn't mean that they wanted it that way. They just said, it's not going to happen in the Delta Hospice Society. We will not be doing this. But what happened is the government said, but you have to. So what the government did is they defunded them, and then they expropriated their 10-bed hospice. So can you imagine a government? Now remember, the building was owned by the Delta Hospice Society, but the government expropriated the building. So that pretty much shut them down. So they've been trying to set up a private setup, and the government's been standing in their way also for setting up a private thing. So it's all been a problem. Just recently in Quebec, and here's a little information about Canada also. Quebec has a different law than the rest of Canada. Now, if you know anything about Canada, Quebec's always different. Nothing personal. No one here is from Quebec, but anyway. The point of it is that the Quebec just extended their law, similar to what the federal government did. A little bit different, though. One of the things they put in that bill is that all palliative care institutions are now going to have to provide euthanasia. So therefore, they've taken out that exemption of the religiously affiliated groups. And so this is a serious concern also. So now I have been talking to quite a few groups, and they're talking about doing a legal challenge to that. So what am I saying? What's the other effect of legalizing? Well, obviously it changes a lot of things, but it also changes the way, if you want good end-of-life care, it changes the way that's provided to you. The other problem is a lot of the palliative care doctors have left. So I have a good friend, he was a full-time palliative care doctor in Mississauga. After it legalized in 2017, he had 3 cases where he had patients who were asking for euthanasia. He did not refer. He did not believe he should refer. In Ontario, he has to refer. So there was a lot of pressure put on him. So he decided it's not a safe place for him to stay. So he left palliative medicine and he started a pain clinic. So he's running a pain clinic now in Brampton, but it's got nothing to do with palliative care. You know, you could have sports pain. I run, so I've got a bad hip, things like that. Anyway, the fact of it is he said, I'm not going to refer. I'm not going to do euthanasia, and I'm not going to refer. I better get out of that area because I'm not safe. But you see, that's a trained palliative care doc who had experience, and you lose them. That's serious because we all want good end-of-life care. That's what we want. And will you get it now? And the answer is it's becoming very difficult.
Thank you very much. It's really hard to get words to answer that. We are, I suppose, those of us in palliative care, been following what happened with Delta Hospice very closely.
Yeah.
Very closely. I just actually want to acknowledge, and it's rather than a question, it's kind of a statement from a member of the attendees, one of the attendees. They actually wanted to acknowledge that some politicians were invited here today and haven't actually attended, and they just actually wanted that acknowledged, particularly in the light of the current Dáil committee, you know. Oh yes, apologies. Would you like to?
I was waiting for other people to speak. But
No,
I speak very loudly.
Okay, all right.
I'm a retired doctor, and I just want to mention that Doctors for Life and Irish Catholic doctors do exist in Ireland, in case you don't know it. I want to make 2 comments and ask questions. One of them, of course, would be the important one. What are we going to do now out of this meeting? Could we have even a time frame of what's happening in the Oireachtas, and what can we do as groups and so on? Can we speak, or what can we do? That was my primary question. The other one is a question, a comment. I've experienced in my life 3 deaths. One in England, a friend died from the Liverpool care plan, for those who know.
Yeah.
That was replaced by Nice, which is equally bad, right? The second death I saw was in the hospice here, and of course I'm interested in what you think of this. I believe that there is a euthanasia going on in our hospitals, in the sense that people are denied fluids quite often towards the end of their life. Please comment on maybe. The third I experienced only a few months ago in a general hospital. A lady got a stroke. She was unconscious, but she was moving. She was able to. she could have been fed, she could have been hydrated. I have experienced other friends who had massive strokes and recovered from them through wonderful care while they were unconscious. This lady was, as I say, there was a bit of a consultation what we do with her. She was denied fluids, any feeding, anything, and it was a decision that I think, and then of course the inevitable syringe driver, and she was dead within 10 days. And I'm certain she died from lack of nourishment. And I would be very grateful for your...
Okay, I suppose there's a lot there. I'm sorry, I missed your own name?
Janina Lyons.
Is it Janina? I missed your, okay, so I think there's a lot there. I'll take a step at a time. And some of the other panelists will probably want to answer as well, particularly regarding stroke management.
Yeah.
So just to clarify, we don't practice Liverpool care pathway here. That's another longer discussion. That's another longer discussion. We don't practice that here. We do, however, recognise that it's really important that people who are dying die with comfort, die with respect, obviously die with dignity, but actually that their symptom control is extremely important. You brought up a very important issue there in terms of talking about fluids and about the syringe pump. Okay, so I'll deal with the syringe pump first, if that's okay. People do not die because they're on a syringe pump. A syringe pump is intended really just if someone can't take their medication by mouth. Say if a person actually has an illness, has cancer, or has breathing problems and they're on regular morphine for symptom control. Or it may just be actually that they have nausea and that they're on regular anti-medications. If someone can no longer take their medication by mouth, and that could be because they have a few days of vomiting, there's no point giving them medicine by mouth. So what we do is use an alternative. Instead of actually someone having to go through regular injections, which none of us would want, so instead of having to get regular injections, what we use is what we call a syringe pump. It's about this, a little bit bigger than our phones. A little bit bigger than our phones, has a little syringe attached to it. We can put anti-sickness medicine in it, relaxation medicine if the person needs it, some types of pain relief, and medication for a certain type of destinies that people can get as they're getting closer to dying. It is not used to hasten death, and I'm really glad you brought that up, because actually that's really important for people to know. We put syringe drivers up if someone can't take their medication by mouth. Equally, and we take them down if someone is now able to take their medication by mouth. They're not used to hasten death. I wouldn't want that concern to be there. Thank you very much. The other one regarding fluids. We do actually, so I actually obviously don't know what happened in those individual cases, but I'm really glad that you brought up the concerns. A point does come, sadly, when someone is dying, that they're no longer getting benefit from fluids. If someone needs fluids for their body, they should get it. They should certainly get it. We don't want anybody dying from lack of nutrition or from dehydration. But when someone is dying, a point comes, unfortunately, where their body is no longer able to take external fluids, where they're no longer actually able to get fluids by vein or in under the skin, what we call subcutaneously, because the side effects get too great. It's actually a part of the body weakening and getting closer to dying, and it gets to the stage, unfortunately for people, as they're getting closer to dying, when the side effects outweighs the benefits. But if someone needs fluids and it's of benefit to them, we do give them to them. So I just want to clarify that, but I don't know what happened in those individual cases. And I'll just pop on to Des about the stroke management, okay?
Sure. I mean, generally we provide people with fluids until the point it becomes troublesome or burdensome so to do. So tube feeding is very difficult. It's actually been shown that if you tube feed people living with dementia, you probably shorten their lives and you don't improve any of their other conditions. You need to have people at 45 degrees. It's difficult to nurse them. They may find it, they may not want it. People can consent right to the end. Very often people with dementia, they certainly don't want to be prodded or poked with a needle. We can do a thing called subcutaneous fluid, so you put a needle under the skin, but you can only do that for so long. And again, it comes to a point, and again, I think certainly within, as you're aware, within Catholic thinking, there's ordinary and extraordinary measures. And there really does come a time where trying to continue to give people fluids when they're clearly actively dying is not appropriate. So I would have to say, again, I can only speak of the experience of the hospitals I've worked in, but I found out generally that people are very humane around this. Generally, they're very quick to get a second opinion if they're not certain. And we're somewhat reassured by literature from the oncology palliative literature, is that people in these settings don't report feeling thirst or hunger. And of course, we're very keen to make sure people to keep doing oral mouth care as long as the patient's willing to do it, so their mouth is kept hydrated. But of course, we'd always say, if there's ever a concern, please always ask for a second opinion. Around stroke, it's very difficult to give you an answer on an individual case, and certainly we would counsel several weeks before we decide that this looks very much like palliative. It may also be very challenging to provide food and hydration in these settings. You may have somebody who's batting away or pulling out drips. We don't, and I mean, when I started medicine, like in the mid 80s, they were doing things which were actually crueler in a way of putting people into sort of mittens or restraining them when clearly they were distressed and they didn't want the drip. We're now understanding that a person living with dementia, right to the end, if they're pulling out that drip, they're telling you they don't want it. So, look, I can't say it's all perfect out there, but I'm reasonably reassured by what I've seen across 2 large teaching hospitals and a rehab hospital in Ireland, but I can't say that's necessarily universal.
So in Canada, a lot of the argument was made that, there's abuse of palliative care going on already, isn't that the same as euthanasia? This is one of the things the other side was constantly bringing up. And then they said, well, we should legalize it so we can regulate it. That was their argument. So, I'm not suggesting, I'm not here in Ireland, so I don't know what is happening here. I'm not assuming that every physician is fully ethical. Nonetheless, the fact of it is you will hear that from the other side, who they'll say, certain things are happening already, we need to legalize this and regulate it. What we've actually found is, of course, that when you legalize, you actually get it actually becomes worse. And I think Gordon's data was showing that clearly, that in the Netherlands, you see this very high use of continuous sedation as the person's nearing death. I mean, beyond the numbers that you would even dream of here in Ireland. And we've seen the same thing now in Quebec. Now, why do I use Quebec as an example? Because Quebec is the only place in Canada where they're actually, how would you say, analyzing this stuff. The rest of Canada, it's just like, we see, like if you look at the data out of Canada, it's really, if you want to find anything at all that will tell you that there might be a problem, you have to look at the Quebec data, because they're the only ones who are actually looking at the records. They're taking, emphasis on looking at the number of people who are being long-term sedation, things like that. And we're seeing once again in Quebec, similar to the Netherlands, the massive increase in those numbers. Not to say that it isn't necessary at many times or even sometimes, but nonetheless, when you start looking at that massive increase, you start asking the question, well, what's the intention of it when you're getting to that point? Nonetheless, I'm saying what I'm getting to is it's worse once legal.